Okay, so I guess I'll talk a little bit about my experience in working in mental health. So I've worked in psychiatry for about 20 years now, nearly 20 years. I've also had my own mindfulness meditation practice, and through the course of that, I guess that I've had two educations, if you like. I've had the standard education, which is kind of learning about the mind and breakdowns and mental illness and things like this through the usual textbooks. But I've also had a bit of an education through exploring my own mind through a kind of subjective process of meditation over the years. And it's given me a bit of a kind of a two-sided approach in terms of understanding how things work in the world of mental health and how we can do things to improve outcomes for people and help people make sense of what they're going through. So we start off by talking here about what the traditional definitions of psychosis are here. And traditionally we define psychosis as basically a difficulty in maintaining one's boundaries between self and non-self. So you'll have people describing things like saying that they're a flower, they feel like they're everybody, and there's some sense of omnipresence almost in the psychotic experience, which is quite common. And the quotes in here are examples from patients I've had over the years who have either reported this themselves or that the staff working with them have reported this kind of thing. And you'll see here that interestingly, we can start to see some similarity between some of these experiences that are traditionally defined as psychosis and some experiences that people have that actually relate to what people refer to as kind of spiritual awakenings or mystical experiences. So the top quote there is from a physician who actually didn't have any spiritual beliefs or anything himself, but one day he had a bit of an experience that made him kind of look upon and think of the world very differently. There are quotes like this from lots of people, including astronauts. His son Edgar Mitchell is one of the original Apollo astronauts, and he described an experience he had as he was coming back to Earth and a profound sense of connection. And then below here there's another quote from somebody who experienced a breakdown himself, ended up in the psychiatric services, and there's a lot of parallels between the two. This is another quote from a reverend, Professor John Hicks, who's an author and was an academic theologian, and he described his own experience once after meditating, in which again he felt this kind of profound sense that previously there was a sense of being me and not me, there was a sense of the world and then yourself, so there's kind of a dichotomy, division between me in here and you out there kind of thing, the rest is all out there. And this very accomplished academic described his own experience through meditation, which was very profound. This has nothing to do with ending up in mental health services or anything like that, but it was a very profound experience that he had. And this is another quote by a chap who'd been meditating for many years. He was a businessman, and he remains a very successful individual. He's now a teacher, and he had a similar experience to that which was described by Professor Hicks in terms of the difference between his ordinary consciousness experience and then a sudden experience he had, in which he kind of felt very different. And as you can see here, I won't read the quote now, but as you can see from looking at the quote, there's a real sense of connectedness, interconnectedness that was very profound in what he actually experienced. And so this quote makes a lot of sense in that context. This was a publication by the Royal College of Psychiatrists by a couple of prominent psychiatrists, including Professor Chris Cook and Andrew Sims. And they essentially describe here that phenomenologically there's been a number of studies that try to compare mystical experiences like the ones I've put up there and psychotic breakdowns. And they found that phenomenologically you can't actually distinguish between the two. People who are having these kind of spiritual type experiences and people who are having psychotic breakdowns seem to be having something very similar going on. To the extent that you couldn't, just by reading the description, describe which is which. The only way you can really tell the difference is by seeing what's happened to the person afterwards, how it affected their life. So there's a kind of profound connection between the two experiences here. And I think that in terms of understanding what people's mental health problems are all about, I think it's very important for us to try to unpick this, to try to understand what does this mean, why is it so similar, and why is there such a high proportion of people who have had psychotic experiences who have very deep spiritual elements to their descriptions. One way to handle it is just to ignore all of that and say it's all pathology, but another way is to actually explore it and try and see why it is that there's such resonance between these two kind of populations of people who seem to be coming from a similar place. And there's a little bit of a metaphor here that shows us that this kind of dilemma, this kind of existential question almost, has been asked for thousands of years. So Plato, about 2,500 years ago, wrote an allegory of the cave, and it was a very clever way of trying to explain what might be happening here. In that, if you kind of imagine a group of people who were brought up in a cave, and they're kind of tied to some poles, so they can only see in front of them, and there's a fire going off behind them. So what that shows is that they're only able to see the shadows in front of them. They can't actually see reality itself. The first person who breaks through and comes out of the cave and sees what it's really like outside of the light will have an awakening, a very different experience of reality. But when he comes back and tells everybody else, they'll think that he's mad, because that's all they've ever seen themselves. So it's very possible, through the experience of some of these breakdowns, that there is some authenticity going on. There is something else that they're connecting to. And this is not something that I've just discovered, but it's been talked about for thousands of years ever since Plato. So there's something here about people breaking through something into some other kind of experience which is beyond what our kind of normal sense experience teaches us. And psychology these days, there's lots of experimental psychology that can scaffold us into an understanding of this. Because essentially, when we are born, we form neurons at a very rapid rate. So you'll see here we form about 1.8 million synapses. The synapses are the connections between neurons. We form about 1.8 million synapses every second. So babies actually hard at work. All the stuff they're doing, looking at their hands, putting things in their mouth, they're forming connections at a really rapid rate. And then at some point, a couple of years later, they undergo something called sculpting. So a huge proportion, about 50% of all of their synapses, start to die. And as a result, they're left with a specific kind of brain structure that is their way of understanding and interpreting the world. We've all been through that process. And we all think that our way of understanding the world, of seeing it in the dimensions that we see it, is how it is. But we would say that because we came through the same process everybody else did, and we were influenced by our parents and by all the cultural influences and the familial influences we've had that help us form this kind of experience of reality. And I guess I begin to talk a little bit in the book that I've recently published about how there's a real sense in which, although we've all been through this process, we've kind of formulated a way of seeing the world which has been evolved as a result of our experiences in our lives. It isn't something that's kind of necessarily out there. There's something about all of our experiences that gives us the interpretation of reality that we have. And as I said, this is becoming increasingly understood in experimental psychology these days. So this quote is from Professor Stephen Hayes, who's a very, he is the founder of something called acceptance and commitment therapy, which is one of the fastest growing therapy models in mental health today. Their research base is evolving really quickly, actually. And he talks very much about how when a child is first born, they gain a sense of self. So a small infant might be asked, what did you have for breakfast today? And she might report what her brother had for breakfast. And the mother will correct her and say, no, that's not what you had for breakfast, that's what your brother had for breakfast. What did you have for breakfast? So this is how over time you get to learn the existence of a me and a you, of a here and a there. You develop a locus of control of reality. So there's this kind of sense of being separate from reality which evolves through your childhood over the years. And I talk about how this is kind of formed into our sense of self. This egoic sense of self is something that enables us to operate in the world. But it is something that we have learnt over our experiences over the years. And over time, this sense of self, we add more and more things to it. So what you define as yourself, the idea of being you here now, starts having lots of things attached to it in terms of who you are as a person, what your likes and dislikes are, what your preferences are in the world, and how you go about things. And so you develop increasing adjectives and understandings of what it means to be you. And this, of course, gradually builds in your thinking mind. So we have a thinking mind which kind of adds layer upon layer to this idea of who we are, and we kind of build that outwards over time. And of course, the way that we do that with our thinking mind is we start to judge things. We judge things as separate, and we're constantly making judgments. And language, which is the tool of our thinking mind, and the logic that we use is the way in which we try to measure things, to understand things, to distinguish things. And we're constantly using that tool to kind of judge what reality is, where I am, who I am, what's this room I'm in, how far are those walls. We're making judgments the whole time. And as a result of that, our thinking mind, which kind of forms this sort of separate sense of self, our thinking mind is constantly essentially filling with all sorts of thoughts and judgments. So we're kind of thinking our way through the day, and this picture is a little bit of an example of how our mind is full of words. So the linguistic mode of understanding is kind of fundamental to how we tend to understand reality. So we're always using language and understanding where we are and where other people are. So there's this constant kind of judgment going on, there's this constant analysing going on. And that kind of verbal analytic function is the kind of fundamental kind of function that we rely upon to understand what reality is and who we are. And of course, what that inevitably leads is that can sometimes start to get out of control, that can expand. In fact, that will inevitably expand in all of us, that will inevitably go into a vicious cycle. So this kind of, so it starts then with this idea of being a separate sense of self, and we start to use words to define that. And this kind of words and thinking modality helps us define ourselves as separate in reality. And as we do that, we start to use more and more words, and the analysis grows, and the description of ourself grows, the description of the outside world grows, and we kind of grow this kind of constant thinking process that is something that we are all subject to, we're all victims of. And it's quite easy to demonstrate that we're all victims of our thinking mind, because I've spent a number of years in my mindfulness meditation practice, and there's others here who I've met for similar, engaging in similar practices. And if you just try and sit down for 5 minutes and observe your breath, for example, just something very simple, like let me just observe my breathing, you'll find that you can't actually do it, because your thinking mind will kick in, even though you didn't want it to. So our thinking mind actually has a kind of energy of its own that keeps going around, and we're constantly engaged in that process, which is why we're always constantly feeling the fear of breaking down ourselves, and that fear exists in everybody because of the nature of our thinking mind, which is constantly whirring. And of course, the permutations within which our thinking mind can take us to different places, to difficult places, to unhappy places, is almost infinite, which is why they can never kind of write enough pages in the DSM, because it's an infinite permutation. There's as many permutations as there are people in terms of the way that our thinking mind can take us in all sorts of directions, which is essentially what's happening in kind of breakdowns. But what's really interesting is that even through those breakdowns, even through this hyperactivity of the thinking mind, there's something that creeps through, which is why what I was saying at the beginning seems to be really true. In my nearly 20 years in mental health, those people who have had severe psychotic breakdowns, I would say that it's only a small minority that don't have a strong spiritual construct within their experience. They feel something that's strong is connecting through this process. And essentially, it's almost as if their ego, if you like, their sense of self is breaking down, and as it cracks, there's sort of gaps in the cracks occurring, and there's some kind of sense of something beyond it that they're connected to. Very hard for us to define, very hard for us to put words on, but there is something that seems to be creeping through. And if you do a survey, there was a survey actually, I think there was a large survey, a large cohort of people who'd experienced psychiatric symptoms were asked how important spirituality was to their life, and 84 of them said that spirituality was very important to them, which is something like 10 times higher than the average population. Okay, and it's very likely that their experiences have given them a sense of something spiritual out there, which they can't necessarily connect to, which all of us will have difficulty in fully grasping and understanding. But there's something that they seem to be touching through these experiences. And again, you can see here examples of how people. So the latter example, the lower one, with Dr. Edward Whitney, who was a GP who had his own psychotic experience, and he described how, very interestingly, the way that he had been treated by the system meant that everything that he experienced was pathologized. It was all sort of defined as illness. as a result of that, he felt that some of the insights that he had, some of the real kind of authentic connections that he felt he had made were all dismissed, and because of that, something had been missed by people who'd looked after him. Of course, he had a lot of distress, and he needed help to get through that, but at the same time, he felt like the baby was being thrown out with the bathwater. There was also something real in that experience, and it was a great shame to discard that altogether. And there's an excellent study by Charles Harriot Maitland, and essentially what that shows is that the way that we can do something about this is essentially through a process of validation. Because I now teach psychiatrists mindfulness meditation, so I run retreats for psychiatrists and I run retreats for a number of mental health professionals. And it's amazing the amount of people who are very open to this understanding. The number of psychiatrists who I've had say to me that I always thought there was something authentic in what they were experiencing, but there's no paradigm within which we can understand it. At the moment, we only know disease and normal, you know. There's nothing in between in terms of, actually there may be something authentic within that turmoil process. So it turns out that if we have a slightly different attitude, and we don't necessarily have to buy into any spiritual concept or anything like this, but if we have a slightly different attitude in which we are able to give some credence and some validity to people's experiences, as long as it's compassionate, as long as it serves them, as long as there's something positive about it, then that itself, just that attitude itself, can have a difference in outcomes. So what Charlie did in his study is he basically looked at two populations of people. One population who had psychotic breakdowns and ended up in hospital, and another population who had psychotic breakdowns and didn't. They had kind of non-ordinary experiences, as they're called, and never came into services. And he looked at what is the difference between those two. What's the difference between one population who ended up repeatedly coming to hospital and the others who had their experience and were able to carry on with their lives? And the biggest difference was validation. Those people who were able to integrate their experience into their life and carry on with their lives had a community around them who could validate their experience and say, well, it's not all nonsense, it's not all illness, there could be something genuine in what you're experiencing. And they accepted what they were going through, as long as it wasn't leading to any imminent harm to themselves or anybody else. That validation actually led to really different outcomes from these people, and not, in the end, dependent on services. So essentially, validation is the key, and this is some very well-known studies which I learned about in medical school, and then again when I did my exams as a junior doctor in psychiatry, and it's very well known. But it's a little bit of an embarrassment really, because you see these are WHO studies that have had sample sizes of 5,000 and 10,000 people all around the world, in the developing world and in the developed world, and these are very well-known studies, and they've been repeated time and time again for the last 30 years, and they've consistently shown that relapse rates for chronic illnesses, so-called chronic illnesses like schizophrenia, seem to be lower in developing countries than they are in the West. Now, this is clearly an embarrassment because that really shouldn't be happening. And one of the reasons why this is hypothesized, this is the case, is because there's a social network that validates people's experiences, that makes it more likely that they can integrate them into their lives rather than trying to remove them reflexively just because they're there. And that difference in attitude makes all the difference in people's outcomes. And it's one of the reasons why potentially, if you live in a developing country, you're in many respects more likely to not return to having these kind of experiences and relapses than if you lived in these countries. And that's been repeatedly shown over the years. Now, one of the big differences with being looked after in those parts of the world to being looked after here is that what we tend to do in services is we tend to ask our clinicians, like myself and nurses and others, to actually substitute a bit of a social network for the people who come to us. So we sometimes replace that. But the difference is that it's not reciprocal. We're not engaging in a mutual relationship. And that therefore doesn't lead to the kind of validation that some of these studies show that can make a real difference. So because we're kind of substituting rather than actually engaging on a more human level, what it leads to is a kind of sense of dependency, where you've got people who have had the experience and the clinicians who are here to fix it. And because there's that dichotomy, it leads to a dependency in the long term. And people kind of defining their experiences purely in terms of being unwell or needing to be fixed, and then that leads to people staying in the system. Now, open dialogue is a very different approach, which was invented essentially in Finland. And what they did there is that they showed that you can help people with their outcomes without necessarily doing anything. You don't have to kind of engage yourself in a spiritual belief system or anything like that. It's just about listening to people. And that takes a lot of practice. What they essentially have done in Open Dialogue is they have taught all of their clinicians, doctors, nurses, OT, social workers, to learn family therapy and systems therapy and to work with whole social networks rather than with individuals. So in that part of the world, what they did is they never saw people on their own, they only saw people with their whole network together. And they worked as a group, with a group. And they learned themselves about techniques to, without pathologizing people, just actually sit with people's difficulties, tolerate them, and see if there's a way to kind of validate and understand them together. So each patient journey is a unique experience. We don't come to it with this idea that, okay, I know what diagnosis he probably has, this is what I'm going to do. Actually, the clinicians share with the patients and their carers a journey that they go on together. And each journey will have its own different outcomes, but in the end, it seems to make a big difference. There are several core principles to Open Dialogue, which I'll run through very quickly. One is the provision of immediate help. Another is, as I said, working on a social network basis only, so not working with people one-to-one primarily. And dialogism, which essentially means making sure that every voice is heard. The understanding of psychopathology in Open Dialogue is that one of the reasons why people have breakdowns is because there isn't an avenue through which they can be heard, and their symptoms often become a way for them to communicate. So it's making sure that the primary purpose of the intervention is to facilitate communication for everybody, so everybody's adequately heard, and so the system creates a kind of mutual network where everybody has that space. So it's creating that space. And what that means is that it isn't going to be a clear-cut trajectory. There will have to be tolerance of uncertainty. So the clinicians then need to engage in terms of being able to tolerate where will this take us. You know, it's a more democratic, less hierarchical way of providing care, and so there's more openness in the system. And of course, you know, if there's any imminent risk, then there's the kind of traditional means of Mental Health Act and things which they have there too. But actually, it's about all connecting up together and being able to tolerate the distress that's in front of you. And one of the reasons why this often doesn't happen is because, as clinicians, we often don't like to tolerate distress. We want to keep it out there. But actually, the clinicians in Open Dialogue are taught to be able to sit themselves with distress and not reflexively and immediately try to remove it. Responsibility is another key one, where you have the same clinicians working with the same social network throughout the care pathway, so they don't keep changing like that often happens in services today. And again, that psychological continuity there too. So you've got the same people from the very start working all the way through. And flexibility and mobility. So, you know, all other systems of care are open in Open Dialogue. You know, it's a pragmatic system where people are able to bring in medication or other things like that, or hospitalization if necessary. But we work on it together. It's not the professional telling the patient and their carers what to do. It's a lot more of a democratic approach. And core to it is being in the present moment. So without necessarily responding to a set of ideas and templates or assessments we have in our heads, it's reacting to what's happening in the network in the here and now. And actually working that way takes quite a bit of training, rather than trying to extract information, which is what we tend to do as clinicians. We try to extract information or deliver information. But this is different. This is about trying to be in the moment and trying to react to what's happening in the here and now. And that requires some training. And this is why it's also a mindful approach, because some of these core things, like tolerating uncertainty, and like allowing the space between things to emerge, this is very related to mindfulness. So I'll mention at the moment some training we're now delivering across the NHS and Open Dialogue. And a core component of that is the mindfulness training, which people are gaining a lot of benefit from. Just being able to be present with your own distractions, your own turmoil, really helps create that space. Tolerating the certainty within yourself helps you to do the same with the patients that you look after. So that's a core part of the training. And these are the outcomes that they got. So they've been followed up for about 30 years in Finland. And you'll see here we've got Open Dialogue versus treatment as usual. After 5 years, 82%, well, a 2-year follow-up, 82% actually were back to work or study, compared to treatment as usual, which is 50%. And actually in this country it's even less. So we have less than 50% of people who have a psychotic breakdown who are back to work or study in this country. A lot less than that, actually. But in Finland, they were well over 80%, so very, very different. And yet, at the same time, so the relapse rate was a lot lower. Treatment as usual had a 70% relapse rate. Yes, and it's 24% relapse rate in open dialogue. And then also there's a big difference in who's claiming disability allowance. There's a massive differential there. And in terms of, but yet, use of neuroleptic medication was a lot less. Only a third of the people used neuroleptic medication in open dialogue in Finland, compared to 100% in normal treatment systems. And hospitalization was a lot less as well. They were, on average, hospitalized less than 19 days compared to treatment as usual. So you can imagine that with results like this, people have been trying to take it on board quite rapidly. They haven't had randomized trials, but these non-randomized trials have been so marked in their outcomes that essentially most of Scandinavia are now using open dialogue-related systems. It's taking off in a big way in Germany. There's hundreds of people and trusts trained in open dialogue now in Germany. And in the States, at the University of Massachusetts Medical School, there's an Institute of Dialogic Practice at Massachusetts, and they do a master's degree there. And they spend about $50 million on an open dialogue service in New York, which is now up and running for a couple of years, and also in Vermont. So there's several US states now that are taking off open dialogue services. So it's beginning to catch on around the world in quite a big way, because when you have such a marked difference in outcomes, it's inevitable. And as you can see here, I mentioned some of the countries that is taking off in. Now, in the UK, we've now, for the first time in the NHS, started to launch an open dialogue pilot. Let me just check what the next slide is. Yeah, so essentially what we've done is we've got 4 trusts together. So there's my trust, North East London, there's North Essex, there's Kent, and there's Nottingham. There's about another 7 trusts who are waiting to join the second wave. But our 4 trusts now have allocated 1 service in each trust, which we are going to form what are called peer-supported open dialogue teams, which will be working on this basis. We will be training our staff for a year. The training actually started last week. And it will be 1-year training, so we're kind of having 4 residential weeks together to learn this methodology. We have 11 trainers from about 5 different countries flying in to teach us how to work this way. At the end of this year, so in October next year, we will then start to launch the open dialogue services in each of these trusts. And we'll be measuring our outcomes compared to treatment as usual over the next several years. And we hope to develop an evidence base in terms of a randomized controlled trial to demonstrate the superiority of this kind of service. And if it does come out, as we hope it will, and certainly if the evidence repeats the kind of evidence that we've had around the world, then I think it will be quite a compelling argument to start to move in this direction nationwide after that. As I said, there's a number of trusts now queuing up to be in the second wave of the pilot, all raising money internally to try and engage in the training for their staff. A particular innovation we're using is something called peer-supported open dialogue. A number of trusts are very big on peer support these days. They're using people with lived experience themselves to work in their own services. Nottingham, for example, has 2 peer support workers in every single team. So we've made sure that every team that joins in the pilot has ideally at least 1 peer support worker themselves. We're also recruiting a series of voluntary peer workers to join with the team to facilitate the rolling out of the model. So it's very integrated with peer work. And I didn't invent this myself. In New York, that's exactly what they did. So when they set up an open dialogue service in New York, they used a body called Intentional Peer Support, which has had years of experience. It was set up by a woman who's a social worker who herself had a breakdown, ended up in the system, was quite shocked by what she experienced on the inside, and so started to create some courses in terms of teaching peers to help others. And this intentional peer support is now spread around the world, and the New York service that set up open dialogue worked with them to form a combined service. So we have kind of used their model, and we're bringing it to the UK, and they will be teaching us, coming over from the US, when we invite our peer workers to our training, which will be in June. So our model is very much peer-supported open dialogue, so it's an integrated model. And open dialogue is just one actually of a number of trials and ideas out there at the moment in terms of moving services to a more humanistic, more kind of holistic model, where we're actually working with people, and we're open to a variety of methodologies. Medication and biological methods will have a place, but they aren't the only way we do things. And we work with staff in terms of helping them to work with people in this kind of way, and working with whole networks. So, as I say, open dialogue is one model, but there's a number of different models, and they're all about trying to engage more, to collaborate more, to connect more, to listen more, and therefore to help people at a deeper level, basically. and it's kind of a group of different bodies coming together to form what's called the New Paradigm Alliance, which is due to be launched probably sometime next year, which, as I say, is a group of initiatives coming together to kind of just network and talk and encourage each other about moving in this direction in services. And just to finish with, this is a book that I wrote about my own understandings of these things, about my own experience, and looking at the difference, looking at the commonality between some experiences that people have through meditation and through spiritual practices, and the common ground between that and the experiences that people have when they're breaking down. So it's just kind of connecting those two up, which is the kind of theme of the book. Okay, thanks very much.
Thank you.